So I'll introduce myself again. I'm Emma, I'm Chief Executive of Endometriosis UK. I'm delighted to be joined by Andrew Kent. Andrew, I was just thinking actually, Andrew was one of the people I spoke to quite early on in my career. He, Endometriosis UK very kindly showed me around his team at Guildford, and so I've always been very grateful and very impressed with the work that Andrew does. Andrew Kent is president of the BSGE, the British Society for Gynaecological Endoscopy, who, as you know, are the organisation that accredits specialist centres and sets standards for that, and is a minimal access surgery and with well over 20 years experience, I'd say, as a consultant.
Unfortunately, yeah.
I was going to say,
a little bit older now.
Been a consultant at Guildford since 2001, where he's the director of gynecological surgery and research at the minimal access therapy training unit at Guildford Hospital, as well as the clinical director of the MSc in advanced gynecological endoscopy at the University of Surrey. He also served, as well as being president at the moment at the BSGE, he served on the committee, as well as also the European Society for Gynaecological Endoscopy, that's the ESGE. So he's been worked at the UK and European level for many years. And his skill sets include advanced laparoscopic and hysteroscopic surgery, particularly in relation to endometriosis, uterine disease and prolapse. Andrew, is that enough of an introduction for you?
Oh, I think that's more than enough, Emma. Thank you very much for inviting me. That's great.
That's great. I thought, Andrew, so Andrew and I are going to have a conversation with here, and as I say, do ask some questions. We've woven in the questions that you've already sent in, and what we want to talk about is what endometriosis treatment should be like at the moment, but also what we'd like to see it be in the future. So there's some ideas that we come up with. So some of the things we'll be talking about what happens now, some might be things we'd like to see in the future. But I thought it'd be great, Andrew, if you could maybe just kick off by giving us a description of the BSGE and the work that you do there. We talk about the BSGE a lot, but it'd be nice to hear from you about the organisation and what you do.
Yeah, so I mean, the BSG, British Society for Gynaecological Endoscopy, I mean, it was started really when I was a junior doctor, so sort of registrar, senior registrar, you know, by sort of Ray Gary, Chris Sutton, John Newton, amongst others. And Chris Sutton was my sort of consultant when I was a senior registrar at Guildford. So I was actually involved with the British Society of Gynaecology right at the, I suppose, the start of my sort of serious minimal access career. And I mean, it started off with really as a group of like-minded individuals. And the reason I mention this, because it's relevant to endometriosis, as we'll see later on, as a group of like-minded individuals right at the start of sort of gynecological minimal access surgery. So that's not just laparoscopy, it's hysteroscopy as well. So so operating inside the uterine cavity as well as with a laparoscope or telescope in the abdomen and pelvis, and really to promote research, knowledge, and just share experiences at what was a very new way of doing things. Now, obviously, we've moved on dramatically from there, and our society has actually grown from, you know, the tens and hundreds that we had in the 90s to well over 1,600 now. And particularly during the pandemic, we were, well, we were obviously doing a relatively good job, I think, in providing training, because we've got a real surge in trainees joining us, which is great. And now our trainees, our trainees members basically outnumber our senior members. We also have nurses, and again, we're a bit. I found out recently when I went on sort of went on to the ESG board, advisory board, as president of the ESG, that we have welcomed nurses into the BSG, and we have essentially, I suppose, two streams of nurses, along with paramedics, so surgical assistants. Those that are really interested in endometriosis, so our endometriosis clinical nurse specialists, but also on the hysteroscopy side, so our hysteroscopy nurse specialists, and sometimes we find that our nurses do both. So whereas I discovered that the ESG don't actually have a nurse membership category.
Oh, really?
Which, yeah, I know, which really surprised me, because you know, yes, you know, if you're in a surgical specialty, you need to be able to you know, operate, but you can't do it by yourself, and you do need people to help you. And so that's one thing that I have rather suggested to the SG that they might like to consider. But yeah, so it's very different. And I mean, the reason I mentioning how the BSG formed is because, to be quite honest, that's what happened with the endometriosis centres. Sort of back in sort of 2007, 2008. It was a group of us like-minded individuals who realised that we needed to do something more for our, you know, patients with endometriosis, particularly the more severe variants of endometriosis, because again, you have to call them enthusiasts, because you know, right at the start there were people who were keen to do this surgery, but it was new surgery. You know, we didn't then have you know, the advanced energy devices or even the imaging systems and everything that we have now, or even the robotic systems. So things have moved on dramatically, but that's really how the endometriosis centres came into being. And things have moved on from there. But as we'll discuss in the moment, I think we're really need to think about where we're going for the next 10 or 20 years. Great advances, I think, have been made so far, but we need to move it on a little bit.
No, that's great. And as you've mentioned the nurses, I'm just going to pull those in here, Andrew. And in fact, we were talking earlier and saying how important the specialist nurses are. But those are nurses based in specialist centres, accredited centres. And for those of you who are being treated by endometriosis in a non-specialist centre, you might have not actually met a specialist nurse, but they're a fantastic team member, aren't they, Andrew, in terms of having a real skills set?
Oh, yeah. I mean, you're right. I mean, and even, you know, in Guildford, you know, my you know, MJ is my endometriosis nurse specialist at the moment. And you remember Wendy Mitchell, who was my endometriosis nurse specialist, you know, really, when I came up to Guildford and ran through me at Guildford until she retired. They just transform how you can look after ladies that are having, you know, problems with endometriosis. Now, they do not have the time. I'm lucky. My endometriosis nurse specialist, MJ, has 30 hours, which is, and that is her job. She's not doing anything else. But we're really unusual at Guildford to have a nurse specialist who is, her job is looking after ladies with endometriosis and working with us, but also to actually have that number of hours. And to be an endometriosis centre, it does sort of, to some degree, stipulates that you need to have an endometriosis nurse specialist. It stipulates that you need a certain number of hours, but it's sort of something about 10 to 12, if I remember correctly. It's certainly not 30. But even with 30 hours, MJ does not have the time to look after every lady with endometriosis that goes through Guildford, for example. So she tends to concentrate her skills on those ladies that are actually are more complex, have the more severe endometriosis, or are running into problems. So it's not just, oh, you only get to see you know, the endometriosis nurse specialist if you have severe endometriosis. It just depends how complex it is and whether that input is going to be really useful or not. So you do have to direct it a little bit. But yeah, I mean, I don't know what I would do without my endometriosis. Well, actually, I do know what I would do, because for a couple of years when Wendy retired, I didn't have an endometriosis nurse specialist. And one of the battles that I think we all have is actually trying to persuade really the nursing hierarchy that actually these individuals are required as part of your team, and they're absolutely essential. And you have to fight for it. You really, really have to fight for it. And for 2 years, I almost had to create a crisis to actually get them to re-employ an endometriosis nurse specialist, because of course they regarded someone retires, oh, that's cost savings. Yeah. And this is what we're up against the whole time. You really do have to fight for everything.
Yeah, and we'll come on to that later, but I think it is interesting, and it's things obviously that we campaign on as well for access and things like that, but we'll come on to the difference between what should happen and reality maybe in a bit. So Andrew, I thought we could start by talking about what we talk about diagnosis, and we use the figure takes on average 8 years to get diagnosed with endometriosis, and some people have like a brilliant diagnosis. They might go with symptoms, it might be recognized by the first healthcare practitioner they see, and they might have a really short diagnosis, but others it can take an awful long time. So what we have, there are in medicine obviously what they call pathways, which are, if you like, the flows that are supposed to happen to help people through. Do you want to talk us through ideally what would be a good diagnosis process in your mind? So someone's gone to the GP with chronic pelvic pain. I know that there's a real diversity of what happens, but what would sort of on average be a good process to go through?
Right. I think just to say at the outset, what ideally happens now is not what ideally happened historically. And a lot of it is about knowledge at the GP, down in primary care, but also knowledge in secondary care. And so it's really difficult when you look at what we're seeing a lot at the moment is people who've been managed historically. Mm-hmm. Now, one could argue that if you are local to somewhere like Guildford, where you had a high profile endometriosis unit, a lot of those ladies with suspicion of endometriosis, the GPs would pick up on that and refer them straight in. There wouldn't be any sort of messing around. But we all know that just doesn't always happen. And in terms of, you mentioned delay. I mean, Karen Ballard did a lot of work on that. That's where the sort of 8 sort of years sort of came from. When we looked at this as part of our sort of trial for severe rectovaginal endometriosis, if you basically counted the definitive treatment as when we did their surgery, their second stage surgery to sort out the rectovaginal endometriosis, we were finding on average that it was about 11 years, from when ladies first had symptoms, not necessarily diagnosis, but symptoms, to actually getting definitive treatment. And there's various reasons for this. The first one is denial at the patient level, that basically, or maybe not even the realization that what they're getting in terms of painful periods is not what everyone else gets. So it's that sort of not realizing that there's a problem to start off with. You then, and there's loads of factors that come into that. It's sort of peer pressure. Young girls maybe at school, they don't want to talk about it. There's the pressure of work. So, ladies don't want to feel as though, they can take time off because, they're competing in essentially in the workplace with their colleagues. And but then, often when they go to see a GP, the default option, which to some degree, I think sometimes still, well, it does still happen, is, painful periods, that's to be expected. Everyone gets those. And then if ladies are lucky, they might actually be put on the progesterone only pill or continuous combined pill or something. So then what tends to happen there is either the medical treatments control the symptoms, and ladies quite happily go on, usually until the time they maybe want to get pregnant, and then they come off everything, problems come back, and they also have problems getting pregnant. So that's where the other alternative is the medical treatments don't work to start off with, things just get worse, and ladies actually seek help sooner rather than later. Then you get sent up to secondary care, so referred to your hospital, and then really it does depend whether you are seen by an endometriosis, someone who basically understands and can deal with endometriosis. Now, not everyone is the same, and I think this is one of the problems, I think, with the NHS at the moment. There is this, everyone can do everything the same. No, they can't. And particularly when it comes to laparoscopic surgery. So, if you're lucky and basically see a consultant who's understands endometriosis, is good at managing endometriosis by whatever means, but it has to include surgery somewhere along the line, then actually you'll probably get sorted out fairly quickly. You might have a general gynecologist though, who might do exactly the same as the GP. Oh, well, just you're too young to have bad endometriosis. We'll send you off and put you on the contraceptive pill. That can happen starting. So then you're getting almost like a denial in secondary care as well. And then, you know, finally, invariably what happens is things just get to the point that being looked after by a general gynecologist or whatever just doesn't work. And then eventually ladies will find their way to a specialist or a tertiary centre, and then we'll finally hopefully get sorted out. I mean, I'm not even going to go into the different ways of treating endometriosis, because there is no doubt that some work and some don't. But it's, I mean, that's why a lot of people talk about delay, and it's multifactorial. It's just not one thing or another. In terms of ideal pathway, it's basically ladies in the first instance, you know, women in the first instance being aware of symptoms that might be down to endometriosis. Ideally discussing with a practitioner who actually thinks of endometriosis, makes the appropriate referral to someone, to a gynecologist that has an interest and can do laparoscopic surgery as well as the medical stuff. Yeah, and then after the discussion, you actually treated somehow. I'm not going to say whether it's right to just go straight into surgery, but there's no doubt about it. You can control symptoms with medical treatments, and there's some new medical treatments which are coming online as we speak. They're sort of variants of what's there already, but I think certainly they will have a role in managing symptoms until you can get definitive surgery, because at the end of the day, there's no magic bullets for endometriosis. There's no magic diagnostics for endometriosis. It does involve a laparoscopy, but if you're going to have a laparoscopy, ideally you want it being done by someone that can do laparoscopic surgery and can do it well.
No, absolutely. Thank you for that, Andrew. And I think, I think it's one thing we hear a lot is we hear about this, you talked about not everyone being the same in terms of skills. And as I say, we hear some people who have great stories. They were, treated really well. But again, all people who've been seen in gynecology, if endometriosis isn't suspected, they're not seen by someone who's got a specialism in it. So then it all sort of unravels slightly, I think, in terms of the
well, it does. And I do think things are getting better, and this is really where organisations like the BSGE really come into their own, and that's why I'm just so encouraged by the fact that we have so many trainees who are now members, because we're about to have, well, I know I'm going to be seeing you up there, our annual society meeting, our annual conference up in Manchester just after Easter, and there will be lots of trainees there. They will be exposed, to the likes of me and everyone else, talking about endometriosis and hopefully demonstrating some surgery on endometriosis, so they can actually see how it should be done, and that will then roll through the system as they become senior trainees and consultants. So yeah, a lot of the time it's all about education, but in terms of surgery, you can only teach so much. You need to have a certain skill set. You need to be able to do it and do it well.
Yeah, I was quite surprised. Not everyone can do the two-handed thing, can they? Or
Well, no, they can't.
No, it's quite interesting. I didn't realise.
I mean, so for example, some of us use 3D systems. So I'm sure most people have been to a 3D cinema where you put the glasses on, and that's what we call passive polarizing 3D. So you just put a pair of specs on, there's no special headset or anything, and you just watch on screen. So there are, for example, 3D imaging systems which allow that, and what that helps with you as a surgeon is depth perception. So you can actually appreciate depth, whereas normally up till now most of us have been operating in 2D, which means it's harder to judge depth. Now, what is quite interesting is, the reason I mention this, is about 10% of the population cannot, if they go into a 3D cinema, they're the 10% who sit there, put the glasses on and say, well, what's so special about this? They actually cannot see 3D. Some of you may have heard of Snellen charts, which are the sort of color blindness charts. you know, with the funny little pictures with dots on. And some people can't see red, some people can't see green. The same things exist for 3D.
Okay.
And some of the trials that certainly I've been involved in the past with sort of 3D surgery, you can look at these books and some people can see 3D really well, some people can't.
Okay.
So it's not all necessarily down to skill set, although that's a big part of it. Some of it is down to just how, you know, what your makeup is, your genetics.
Yeah, so there's a talent needed as well. Now, Andrew, just to go off on an aside, I realized the other day that we talk about trainees, and some people think trainees are like really, really early career, bottom of the ladder. And actually, in medical terms, these are obviously already pretty qualified people. I was talking to someone who said, oh, I had to see a trainee, and it turned out they'd seen someone who was about to become a consultant. So do you want to just outline basically what a trainee is, just briefly, so people realise what that is?
Yeah, no, certainly. And I think everyone's probably a little bit more knowledgeable on this now following the junior doctor strike, because everyone was talking about various levels of trainees. And it is it's more confusing now than it was when, you know, when I was a trainee, when I was a registrar. So what we used to have was house officers, senior house officers, registrars, senior registrars, and then consultants. So everyone was very clear as to who was looking after them. And basically, at the end of the day, your registrars and your senior registrars were those that were going on to be specialists, were well into their training. And because in those days, I started off doing 100 hours a week, we were actually quite skilled from a very early stage. It's very different now because the European Working Time Directive, our juniors or our trainees will only be working probably about 48 hours a week on average. Yeah. Maybe a little bit more in some cases, but they're sort of graded 1 to 7. So they do 2 years of house jobs. And the reason they have to do 2 years of house jobs now is because they can't get the experience in 1 year like we got, because they're not doing the hours. They have to do 2 years. Then they specialize. So our obstetrics and gynecology trainees basically then have a 7-year training program. But no one wears white coats any longer. You'll see on people's name badges that they will be maybe ST1 to 7, yeah? But unless you're in the know, it doesn't really mean anything. But basically, the higher the number, in theory, the more skilled they are. But it also depends on what training they've had up to that point. So, for example, I have a minimal access fellow, and at the moment it's Samantha Kirkwood, and you know, she came to me as an ST5, yeah. So effectively almost just a senior registrar, but you know, for the last couple of years, for example, she'd done hardly any gynecological operating, yeah. So even when you've got a senior trainee looking after you, to some degree, you're not quite sure what they've done or what they're capable of doing. And you know, what I would hope going forward, and I know the new president of the Royal College, Ranith Thakkar, who works up in Croydon, I think there are moves at the college. They've realised that gynecological surgical training is not what it should be. And, you know, we're trying to improve this now. And hopefully that will sort of align itself with improvements in endometriosis, not just endometriosis care, but I would say, you know, minimal access surgery and endometriosis care. Because I think the two things go together.
Yeah, no, absolutely. No, that's great. And so one of the things that someone's asked is around, just while we're on diagnosis, around MRIs and things like that, and how useful is that? Now, we always used to say, and if you read the NICE guidelines, says laparoscopy is the gold, laparoscopy with biopsy is the gold standard for diagnosing endometriosis. You talk to some surgeons now and they say, well, you know, with the best kit and the best people, I can see whether you know, you've got endometriosis or not. But do you, just briefly, because we could do a whole session on scanning and imaging, but do you think, Andrew, do you think imaging is now for some people getting good so that they can diagnose through that, or do you think it gives an indication?
Yeah, it depends. it depends what you're wanting to do. So, for example, when I do a laparoscopy, I don't just do a laparoscopy and a biopsy. Yeah, my aim when I do an initial laparoscopy is to remove, and I use the term remove deliberately. Yeah, remove all visible and palpable endometriosis that I can within the parameters that I've been set. Okay, and by that last statement, what I mean, if if I've got if someone's wanting to have children, then I'm not going to remove tubes, ovaries, or do a hysterectomy. Right. So that's where you've been set the limits of your surgery. Now, sometimes there are limits which are imposed by the severity of the endometriosis, so bowel involvement, bladder involvement, involvement of the ureters, which makes it more difficult. So you might have to do that as a two-stage procedure. But in terms of imaging, you may get a tentative diagnosis, a diagnosis on imaging. So, for example, if someone's got endometriomas or chocolate cysts, so endometriotic cysts of the ovaries, they're dead easy to pick up an ultrasound. Yeah. But you're quite right. There are some people who would regard themselves as being sort of like ultra skilled in ultrasound, and will suggest that people have got rectovaginal nodules or severe endometriosis, not just endometriomas. But that's fine. But then what are you going to do about it? Yeah. So you're still back to either you're going to put someone on a medical treatment, which isn't going to sort out the endometriosis. It might mask, it might settle symptoms, but it's not going to solve the problem. MRI is probably more universally sensitive in picking up severe endometriosis than probably an ultrasound scan, but that's purely down to who's reading the scans, at the end of the day. Things like CA125, so sort of biomarkers, at the moment, not recommended. Yeah. So my personal, and I was discussing this the other day at a specialist advisory board, personally, I think the best thing is taking a decent history and probably doing an examination will pretty well get you there to whether you need to make the decision or whether it's worthwhile considering doing surgery or not. If you're then going to do surgery, it should be a laparoscopy, what I would call query procedure, laparoscopy and treatment if it's appropriate. Unless the decision is made that actually someone doesn't want to go for surgery, in which case you think of you would consider the other options. Yeah. Having done a decent history and examination, and most ladies will have actually had a scan by the time they get to see us in secondary, tertiary care. It may be, and I don't always do this, you might want to get a scan. The scan hasn't been done already. I would rarely get an MRI unless odds on I think it's severe, and I think the MRI will be useful in helping us to plan what we might do surgery-wise, okay? Yeah. But for me, an ultrasound scan or an MRI is not a prerequisite for doing a laparoscopy if you've taken a decent history and examination, and because usually it's all there if you ask the right questions.
Yeah, and that way I hear that a lot, that actually listening to people, listening to your patients is where it will help. So that's great. Someone's asked what a gold standard laparoscopy would be, and I think I'm just going to echo what Andrew said. It will vary depending on the patient and where the endometriosis is found. So I think the thing is, I know in the text it always says it's laparoscopy and biopsy. That's right, Andrew, isn't it? So it's
well, it is. But as I think is also pointed out in the NICE guidelines, it says a negative biopsy doesn't necessarily mean you haven't got endometriosis.
Exactly. Yeah.
So I think that just to clarify what people mean by gold standard, what they're talking about is investigations for diagnosing endometriosis. So laparoscopy is regarded as the gold standard at the moment because it's the most sensitive way of diagnosing endometriosis. So we all know you can have negative scans, but you do a laparoscopy and you'll pick up endometriosis. Yeah. And it'll be obvious, it'll be barn door. So that's what they mean by gold standard. it's slightly then different to say is what you do at that laparoscopy, and that is where it's entirely dependent on the skill set of the surgeon, yeah, and aligned with the severity or not of the endometriosis, and also what sort of tools you have, as it were, in your toolbox to actually be able to do surgery, yeah, or you have available to you to do it and do it well. But my ideal, and this is what I say to really all my patients, my aim when I do a laparoscopy is to remove all visible and palpable endometriosis, as I said earlier, within the bounds that I've been set by the consent. Yeah. If I cannot do it in one go, okay, then I will do as much as I can, and then we will have a discussion after the operation as to how we're going to take things forward or not, as the case may be. Yeah, but then you are in the position that, you know, from our point of view, and also you know, the patient's point of view, we know exactly what is going on. You know, we know where the endometriosis, we know how severe it is, and what we would need to consider doing to sort it out.
Yeah, no, that's great. And I think one of the things we know about endometriosis is it's different for everybody.
Oh, totally. And symptoms do not necessarily relate to the severity.
Yeah,
you know,
absolutely.
I've seen ladies with what I would regard as quite, you know, superficial endometriosis who have awful problems pain-wise. Yeah, but then I've seen ladies with severe rectovaginal endometriosis who haven't got any symptoms at all, and you just almost find it accidentally.
Yeah, and just from a medical perspective, superficial means on the surface, not that you're being superficial. So I do have people sometimes ring me up saying, my doctor didn't believe me, they said I was superficial, and I was like, the medical, they're using it in a medical term. On that. So
I mean, Carol.
So we've been having a look at what happens at the moment, but one of the things that I'm keen to discuss with you is, and you know, things are improving. I think COVID obviously has not helped with that, and at the moment, and things are tough. But you know, if we were looking ahead, if you and I could redesign the system, so this is looking for future, you know, and how things worked, are there things that you'd like to see done differently, or you know, how would you make sure everyone could get the right care they needed at the right time?
As with all these things, you need people and resources to actually deliver. But at the same time, you also need some sort of structure. And as I was saying earlier, that the way endometriosis centres, and I suppose let's just mention that because it's very relevant, the way they've generally evolved up to now is you have a gynaecologist who has an interest in endometriosis and wants to deliver that sort of, you know, that sort of specialised care. So now some units or some hospitals decide at a higher level they want to deliver that care, so they'll appoint someone to do it. Other times you've just got someone who's interested in doing it and tries to deliver that care. So it's sort of evolved on quite an ad hoc basis, and then it continues to evolve. So when management or surgery for severe endometriosis started to take root, there were a lot of us basically in the southeast. Interestingly, now we don't have nearly so many as we used to have, because a lot of those early adopters, as it were, those early enthusiasts, have now retired and stopped working. And as you mentioned, you know, I've been a consultant now for over 20 years. You know, I'm going to be 60 this year. And, you know, the one thing you learn, well, certainly I learned sort of quite early on in my consultant career, is that, you know, we all get older. No one carries on forever. And but at the same time, you're not irreplaceable. The trick is actually making sure that there is a degree of succession planning and things can carry on. And I think what we need to do now is build a little bit of structure into what has been done already. And what always confuses things, certainly from an NHS point of view, is the sort of continual reorganisations that we get within the NHS. And one of the committees I'm involved in, the Women's and Children's Clinical Reference Group, we were going to be looking at endometriosis centres, and then the pandemic hit. So basically everything went on the back burner for at least 2 years. And So there's no doubt that we need to have a look at what service specification, certainly for severe endometriosis. What would I ideally like? Well, I would ideally like a lead for minimal access surgery and endometriosis in every gynecological unit, yeah, in the UK. So basically every hospital that has a gynecological service, I would love to see a designated lead for minimal access surgery and endometriosis. You also need centres as well, where you can do the higher level of endometriosis, because not everyone is going to be able to deliver the surgery for the more complex cases, because you're then getting into the realms of needing different specialists, so not just gynecologists, but urologists and colorectal surgeons, and an awful lot more backup as well, like the clinical nurse specialists and your pain team, the physio team, your imaging team. Like I said earlier, it's not just one person doing it. That's where the tricky bit is going to come in, is to how many of those centres do we need, yeah, and basically where they're going to be, because what's really important, and you sort of touched on this a little bit earlier, for women with endometriosis, is knowing that they're in the right place to look after them, yeah, because it is difficult. Like I say, if you end up with a general gynecologist doing your laparoscopy, you probably won't have your endometriosis removed, yeah. Whereas actually, say for someone like myself, that would be dead easy, and everything would be done and dusted as a day case. And studies are showing quite clearly, if you do that, then most ladies will generally get better. And that system that I've described is what really happens. And endometriosis is not cancer, but that's what happens really in gynecological cancer care, and a lot of cancer networks, is you have an interested specialist who does, as it were, the lesser complicated surgery out in the almost like the general hospitals, the DGHs, and then you have the specialist centres where the more complicated surgery, the more complicated treatment pathways can be delivered. Yeah.
Yeah, I know. I think for me, I completely agree. I think wouldn't it be great when we get to a situation where you go to a general gynecology department, but they have the right people to see you, but also people know who can be seen by who needs to go to the specialist. Because again, it's always heartbreaking when you hear people who've been seen by the wrong person who then has to send them to someone else, etc. Although with endometriosis, it's never an exact science, so that'll
well, absolutely not. Yeah.
Yeah, and I think for me, the other thing is with centres, you talked about how many centres and where, but also about capacity. Yeah. So we're talking about specialist centres, and these are virtual centres. They're not like the big Macmillan buildings where they actually have a physical building. And one of the challenges I think that we have in campaigning is that we didn't, like pre-COVID, we didn't feel there was enough time given to endometriosis and things like operating theatres and capacity. And now, so we want more of a pie that's shrunk, if that makes sense. And so I think, we have a job to do, and Jess was asking about how to become an advocate or change or improve the situation, is, I think we have a job to do as a charity to try and campaign with all of you to improve, make sure our MPs know what's going on and things like that. So Jess, if you drop us a message, we'll get you involved on that one. But I think this idea of having like a minimal access surgeon and endometriosis specialist in every gynae is right, and it's not actually dissimilar for what it says in the NICE guidelines either, is it?
Exactly. I mean, but to me, it just makes total logical sense. Yeah. Now, to some degree, that might be happening by almost default at the moment, but it does focus everyone's minds if you have a lead, and you might have more than one surgeon in those units doing the operating, but at least there'll be a lead who can basically make sure that everyone's doing the right thing.
Yeah, absolutely. And I think while we're mentioning the NICE guidelines, you mentioned earlier about all healthcare practitioners knowing the symptoms of endometriosis. Again, in the quality standards that went along with the guidelines, and you know this, Andrew, because you're very involved in them, I know, it states that all healthcare practitioners should know the symptoms of endometriosis and consider endometriosis if they see them. And I think one of the questions that we got asked in advance was how can GPs be supported to actually recognise those symptoms and refer on if it's indicated? What do you
Right.
think?
I mean, a lot of it's education. Again, to some degree, one of the problems we've got at the moment, so as well as our specialist trainees, we also have GP trainees that come through our department.
Mm-hmm.
But for example, when I was a registrar, they were with us for 6 months. Yeah. In my trust at the moment, our GP trainees are with us for 4 months. Now, bearing in mind that at least probably a month of that is going to be annual leave or study leave. Yeah. They're with us for 3 months. I mean, I'm lucky if I see them, let alone teach them anything.
Yeah.
So that's difficult. There has been a bit of reorganisation out in general practice now. So again, things go around. So we used to have sort of specialist GPs who used to come and help us in our clinics. They sort of then went out the window. But now there are sort of some specialist GPs that almost like triage the gynecological patients from several practices.
Mm-hmm.
And with the new integrated care systems, I think that's probably more of a model. But we work very closely with our specialist GPs, so that and they are pretty, they're pretty knowledgeable in things like endometriosis. But a lot of it is very much education. You just have to try and just, because it's not a simple thing, and it starts at medical school, to be quite honest. It's not a simple thing taking a detailed gynecological history with a specific relation to endometriosis. But as with all those things, and I was taught this as a junior doctor, you've actually got to suspect the problem to start off with. Yeah, if you don't think about it to start off with, you'll never get there. Yeah, but education is the only way to deal with it.
Yeah, and definitely, I know that the BSGE are working with the Royal College of Obstetricians and Gynaecologists and the Royal College of GPs, as we do, to try and encourage take up of that. And just moving on to another question. So if we're looking in our future world, so we've got these nice hubs and everything, that's great. One of the things that comes up regularly for us is that someone's had surgery, they're fine, and then a few years later symptoms recur. They always feel like they have to start again in trying to get into the system. How do you think we can overcome that? How can we change it so they don't have to prove that they've got it again?
Right, so there is, and I think it's good. So so with our patients, for example, that have severe endometriosis, yeah, fine, we would tend to follow our patients up very, very closely for a year if we've done significant surgery for them. But then we will discharge them to care of a GP, because the one thing that the health systems will not allow us to do is keep someone on follow-up forever. Yeah, it's just not possible, and also it's probably not necessary, in all honesty. But like you say, what people need is the reassurance that they can basically be referred back in. Yeah. So, even if we might have discharged someone to the care of their primary care team, I always put at the end of the letter, but, if there's any problems in the future, just refer back into us. Now, the tricky bit, again, it's all down to systems, is, whether you get referred back in to the consultant that looked after you in the past. So I'm afraid even in my trust, patients get referred back in, and because they're coming in on generic systems and nobody really knows these days, a lot of the younger GPs have no idea who does what. Yeah. Certainly the booking systems, it doesn't go through a secretary any longer. It goes through some sort of booking hospital system. And if you're someone like me that has a long waiting list, often patients are actively diverted away from me to my colleagues. Now, usually my colleagues are pretty good and will say, oh, hold on, you've had significant surgery by Mr. Kent in the past, we'll refer you back to him. But that's actually a waste of time for the patient, because it's a waste of time for the other consultant, because it's another appointment wasted, and it just prolongs the process. There is a system that is starting to come in, which is called PIFU, which means patient-initiated follow-up.
PIFU,
yeah, PIFU, PIFU, but it stands for patient-initiated follow-up, which I personally think is great. So what it means is that there should be a mechanism whereby, and this doesn't just apply to severe endometriosis, this might apply to, a mild moderate endometriosis, not superficial, but mild moderate endometriosis. So if we've treated someone as a day case, and we know that on the basis of the studies, they should get significantly better with what we've done, and that should be maintained up to 3 years. We might not even see them again in clinic. We might just charge them to care of the GP. But if you've got something like patient-initiated follow-up in place, what that means is those individuals can then literally request a follow-up appointment without having to go back to their GP. So that's great for GPs, it's great for patients, and it's great for us. Now, the only little snag in that might be is getting back to see the person who did your surgery in the first place.
Yeah, but you'll get back into the...
But you would get back into the system, yeah.
Yeah, that's great. One of the things that I was always struck by, so I have don't have endometriosis, I have ulcerative colitis, but basically what I have is I'm on a list. Every year I get a phone call asking me if I've got any flare-ups, and every few years I get the joy of a colonoscopy. Great fun. And I think for me there's some parts of the system or some of the cancer pathways where you can do this, and they have really good follow-up. It just seems like for endometriosis somewhere we've not done it yet. We've not, if you like, gone forward with that. And I know some of the GPs have real challenges, like you said, knowing who to refer to, because there's like hundreds of gynecologists, doesn't say who's the specialist.
Yeah, so I mean, I think different conditions are different. So you mentioned ulcerative colitis. I think that ulcerative colitis, it's shown quite clearly that there is benefit in following patients up with ulcerative colitis for all sorts of reasons, which we won't go into. And it's probably worthwhile doing, like you say, a colonoscopy every couple of years. But for endometriosis, that's not the case, because it's so variable. And there probably isn't a lot of point of seeing patients every year if they've been treated well. Again, and this is where you have to be a little bit careful, because there's treatments and treatments. But assuming that you've had the perfect operation and all the endometriosis has been removed, then if you look at the studies, you should get significantly better. Okay. And that should last for certainly for around about at least 3 years. The reason I say 3 years is, even though we tried to follow up patients up to 5 years in our study for mild moderate endometriosis, we didn't have enough people who got to 5 years to make the statistics work. Yeah, so I can say it definitely works for 3 years, but for some people it will work far beyond that. Yeah, and we might never see them again. Yeah, so you have to be really careful that you don't overburden a system with doing what could be construed as unnecessary follow-ups. And that's why I'm quite excited by this patient-initiated follow-up, because that means that actually probably, if that happens, you'll be seeing people who actually need to be seen. And you won't be diluting it with people who are actually sorted out and treated.
Brilliant. Well, it will follow up looking into that and get some information out to people about that. So that's really helpful. Thank you for that. What's going to say? So I've lost my questions. Where have they gone? Here we go.
Well, I mean, there's one that here. I'm not sure who it is, but basically, what is classed as severe endometriosis and what is retrovaginal endo? It's really difficult, because there's lots of people have tried for years to try and create a system which defines what sort of endometriosis you have. I mean, certainly in my view, what it actually comes down to is how difficult it is to treat surgically. And to keep it simple, I personally talk about mild or moderate endometriosis, which might be a mix of superficial and deep, but that's the sort of endometriosis that, with someone that knows what they're doing, can deal with almost like as day case laparoscopic surgery. Severe endometriosis invariably does involve deeper endometriosis, which is harder to deal with. And then I would say you then have what I would call really severe endometriosis. So it's not just rectovaginal nodules, which involve the bowel. It might be significant nodules that are affecting the ureter. that may be causing partial obstruction, or for example, full thickness nodules that are going through the bowel. I'm not even going to go there with what we call extrapelvic endometriosis or thoracic endometriosis, because that's to another different level. Yeah.
Well, we'll do another session on that definitely. And then one of the things that we hear of people is, and we know there's really long waiting lists at the moment, so people might they might be waiting for surgery. One of the things that people find difficulty accessing is all those things that can go along. So accessing pain management, for example. You know, so somebody might, what we often hear, and I know it's generalizing, is that somebody's been diagnosed with endometriosis, but then they're just left on a waiting list for, you know, sometimes a year or two at the moment. Is it worth trying to access local pain management team in that time?
Yes and no. I mean, if you've got an actual diagnosis of endometriosis, that means invariably there's probably been a laparoscopy before, yeah, or you might be dealing with severe endometriosis where it's very obvious on imaging.
Yeah.
But this is a problem, and it differs as to which part of the UK you come from. So I've just been over in Belfast, where we're going to have our conference in 2024, and you know, their standard waiting list for pretty well any benign gynecology is effectively in excess of 3 years. I mean, it makes my year waiting list look positively pathetic. Now, I know it's not pathetic. A year's waiting list is a long time, but can you imagine waiting 3 years for just an initial laparoscopy, an initial diagnosis? And so, yes, you can refer to pain teams, which it can be quite helpful. But like I said, there are some other medications and controlling endometriosis. Surgery will treat it, but you can control the symptoms. And there's a couple of new things that's coming out. So the standard initial treatments are progesterone, some form of progestogen. So Mirena, progesterone only pill, but they only really work if they completely stop periods. Yeah. They might help a bit if they don't. In terms, the other option is what we call a sort of combined oral contraceptive. But if you're going to do that, you don't want to give it cyclically, you want to give it continuously. Okay, so that might be useful as well. But you're really just trying to settle symptoms to the point that someone can manage them. Yeah.
Yeah.
There's a couple of other things around. There's a new progesterone. Well, it's not new. It's been around in Europe for long. It's Dienogest, which is Visan, which I'm sure a lot of people will have heard of. And that is sort of coming onto the UK market for endometriosis. So that will be helpful. And then one of the other things that is a new thing called Rioca, which is Relugolix, which is essentially a gonadotrophin antagonist with built-in HRT, and it's a tablet. So sometimes ladies again will be given injections of what we call Zoladex or Prostat, which is a GnRH agonist, which basically shuts down the drive to the ovaries at the level of the pituitary, at the sort of base of the brain. And I don't use that for treating endometriosis. I use it as an adjunct to surgery without the add back, but you can use that and give HRT add back. But what's quite exciting about Rioca is that it is a tablet. If you are looking at pain, and they looked at basically dysmenorrhea, so acute pain or pain with periods, cyclical pain, chronic pain, and also pain on sex. Certainly for chronic pain and cyclical pain, it does seem to work. Okay, but you have to remember this is not a treatment for endometriosis. It is just to settle symptoms.
Yeah.
And the other problem with all those things that I've mentioned, apart from simple painkillers, is if someone's trying to get pregnant, they're not going to be using any of them.
Yeah.
Yeah, because they're all going to stop you getting pregnant, basically. So it is tricky. I think the main issue, if we referred every lady with endometriosis to the pelvic pain team, they would just be swamped. So certainly at Guildford, we choose very carefully. We try everything we can, okay, and we choose very carefully those ladies that we refer over for specialist pain management if it's required.
Thank you. Now I've only got 1 minute left, but I think, Andrew, just before we go, I mean, I think there are lots of developments up and coming. If you had to pick one thing, and it can be around, you know, changes in treatment or new things coming through or care processes, what sort of, looking ahead, what do you think is something that might be quite interesting coming up that would really help you with your role in supporting those with endometriosis?
Oh, role in supporting. I mean, I suppose with my BSG president head on, yeah, the
Yep.
one thing that I think will make the biggest difference for most women, both now and going forward, is what we were talking about earlier, which is effectively creating a network. Yeah,
Yeah.
a network of care that actually people can access relatively easily. Not just initially, but as we talked about, you know, patient-initiated follow-up as well. Because as with all these things, once everyone knows what is where, suddenly it all just becomes much easier. Yeah.
Mhm.
And everything just drops into place. So if I could do one thing, it would be that.
Brilliant. Well, I think, and I mean, I think that's a really good thing, and it gives us something to campaign for as well.
Absolutely. Yeah.
Which is, and you know, you talked about there's treatment and treatments, and I know that with your work at the BSGE, trying to make sure that all the level of treatment is raised across the UK, not just in specialist centres, is going to make a real difference in the long run.